Well, thank you. And are you seeing my screen now, Elizabeth?
Yeah, yeah, sure.
Okay. Well, first of all, it's a great honor to be here, and for my Russian friends, I want to say "Dobry večer." My Portuguese friends, "Boa noite," and of course, "Buenas noches" to my Spanish-speaking friends, and everybody else, "Howdy," as we say in the South of in America. Very pleased to be here. We're going to talk about respiratory management, of course, which has been a long, important topic in the field and for me particularly. Um, there have been standards of care only since about 2004, and it's actually a parent project that sort of got me involved in this field because I met a lot of families and learned how variable care was depending on where they lived. And so, working with Pat Furlong, we decided to go ahead and just get some care guidelines, and we published those in 2004 in the American Thoracic Society, a journal called AJRCCM, and that's freely available online if anyone wants a copy. And of course, it's been translated into more than one language. And I put this slide up not to say that, hey, my paper is in Italian, but to say that has worldwide acceptance and that it doesn't matter where you live, the approach to the disease should be the same, and that there's a lot of very helpful solutions out there, and it should not matter where in the world you reside. That good care is good care. Um, the standards of care have been updated in 2010 and 2018. All references are available, freely available, and I can give you a copy if you can't find them. And The most recent update is 2018, and we're trying to simplify the criteria for assisted coughing and assisted ventilation, and the idea of starting therapy with higher levels of function. The major approach is preventive. We want to avoid a crisis. I do not want to meet a patient with muscular dystrophy in the intensive care unit. I'd like to meet you as an outpatient. Um, what's new in the 2018 update is the idea of lung volume recruitment, which is the idea of trying to to push air into the lungs, to pop the lungs open and squeeze and to stretch the chest wall muscles. Um, but Duchenne patients and Duchenne parents are really who we thank for the standards of care because if it wasn't for parents advocating for better care, these standards would not exist. Um, the basics of standards of care is that all patients with muscular dystrophy should have access to subspecialty care. It's not just pulmonology, of course, cardiology and orthopedic surgery and nutritional support and occupational and physical therapy. All kinds of people are part of this care team. We're trying to standardize the approach to testing so that everyone is getting the same kind of testing. And in my field, it's pulmonary function testing that should be done on a semi-annual basis in anyone over age 10. Again, we talk about avoiding a crisis. We can almost always predict what the patient's needs are without having to learn them the hard way, shall we say. As mentioned in the video, sleep studies are also a part of standardized testing, and it's going to be important. I'm going to talk about that. And there's an emphasis on not non-invasive support. I know that we talked in the video about a bit about tracheostomy. Majority of patients do not choose a tracheostomy; they choose non-invasive mask support. This is a very simple field. The concepts are very easy. We assist people's cough and we assist people's breathing. That's it. Um, we assist breathing in sleep when the kids are getting too weak to breathe when they're sleeping, and we assist breathing awake later in the course of the disease. And the emphasis has been on non-invasive support. This is a relatively straightforward disease from a pulmonary standpoint, and there are four stages. In roughly the first decade of life, there's not a lot of needs for respiratory support. Um, these, in general, are patients who are still walking. At that point, it's important to vaccinate, and I used to just for flu, but now, of course, for COVID-19, hopefully we'll have vaccination in the first decade. We don't have it right now. I think we have it up to age 12, down to age 12. During the second stage, where in general the boys are all in wheelchairs, um, there is a loss of cough, and you may not be aware that you've lost your cough until you need to cough because of a cold. And so we can predict who needs help with lung function testing. The third stage is having not adequate breathing when you're sleeping. And the fourth stage is having inadequate breathing when you're awake. And the ages vary greatly. I have the first decade of life, first part of the second decade, second part, etc. But those vary really tremendously. And the use of steroids has really shifted the curve by about 3 years. Assisted cough is relatively straightforward now. Access to assisted coughing should be universal. Prior to 2004, these devices were considered experimental. And it was my great frustration that I couldn't get them approved. And it was so out of frustration that I got this paper published. And now I can get these things approved, machines to help coughing. The newer concept is using the machines for coughing for what's called lung volume recruitment. The idea is to sort of stretch the lungs open, pop open your lungs, and get any areas of collapse open back up again. And that's a way of preventing pneumonia. And and stretching the muscles between your ribs, the intercostal muscles can be stretched that way. And we forget that when you have reduced ability to take a deep breath, your chest wall never gets fully expanded, and therefore there can be development of rigidity or stiffness of the chest wall. During the time when we want to assist breathing and sleep, we can always get a sleep study, but the first clue that a person might need help is if their lung function has dropped below a critical threshold. So, as a rule of thumb, we measure how much air a person can push out of their lungs, and that's referred to as forced vital capacity, or FVC. And so, how much you can push out of your lungs is an easy number to measure. It's a volume, and we have predicted values based on your age, height, and gender. And if it's below 30%, you're pretty much guaranteed to need help breathing and sleep. Between 30 and 50, we're not sure, and that's when we get sleep studies. So we start measuring at least once a year a sleep study when the FVC hits 50% or falls below. Again, the FVC stands for forced vital capacity. That's how much air you can push out of your lungs. Signs of having respiratory failure in sleep can be very subtle. And the biggest red flag in the list is waking up with a headache. Um, that suggests that you're retaining carbon dioxide, and so that's a major red flag. Um, Often parents will tell me that their kid used to wake up maybe 3 or 4 times in the night. Now they're waking up 10 or 12 times in the night. Increased awakenings can be a sign of poor sleep because of uh, respiratory failure especially during REM sleep. Daytime sleepiness, not getting good sleep leads to sleepiness during the daytime, and changes in school performance can also occur. You can measure an oxygen saturation if you have a pulse oximeter. You can measure the saturation in sleep, and if it's falling down low, below 90%, that's also a sign that you need a sleep study. But a home pulse oximetry is not a substitute for a sleep study. What we look for is a high level of carbon dioxide in the blood on a sleep study, which can be measured as exhaled or what's called transcutaneous, or having it measured right across your skin. And that tells us, and we also look at what stage you're in, what stage of sleep you're in. Um, this is a paper from 1995 by Liger, and it shows that every patient with muscular dystrophy, save one in this cohort, who had an FVC below 30% needed help with breathing and sleep. And so if you look on the screen, you'll see that there are X's, those are Duchenne patients. And the box with an X around it means they needed BiPAP or breathing support during sleep. Whereas the SMA2 patients did not, the number did not predict. It's very interesting to me how very, very different these two populations are. I always warn parents to be very nervous about someone trying to give their child oxygen. Doctors have a natural tendency to reach for an oxygen mask when they see a person with low oxygen saturation on a pulse ox. Saturation is 88. They say, well, give them oxygen. Makes sense. The problem is that can be dangerous. if you give someone too much oxygen, you will suppress their body's drive to breathe, and that can lead to respiratory failure. And if you fall asleep and you stop breathing, we have big problems. So we do not want a person who's in borderline respiratory failure to stop breathing altogether. And so it's very, very important if someone has a low saturation to know what their carbon dioxide level is. And so low saturation might be pneumonia, it might be just some mucus, but it could be that you're in respiratory failure and you need to measure the carbon dioxide level. I like parents to get a pulse oximeter, and nowadays it's very easy. You can get them on Amazon, or you can get them at the local drugstores. They're between $25 and about $100, and they're worth having in the home. Low saturation is a reason to seek medical attention, but it doesn't mean just give oxygen. So when the boys are in a mode of needing breathing help during sleep, they're always in a wheelchair. And most of my patients choose not to have a tracheostomy placed. Again, if you have respiratory failure in sleep, oxygen is not the answer. The answer is respiratory support in the form of BiPAP, which is also called VPAP. And BiPAP just stands for bilevel positive airway pressure. You can also use a home ventilator. I will make a small disagreement with the video, which CPAP is not helpful for ventilation. CPAP only keeps your airway open. So people who snore use CPAP because it opens up their airway. But BiPAP actually helps you breathe. CPAP just keeps your airway open. CPAP stands for constant positive, as opposed to bilevel positive airway pressure. So the key thing is to get a sleep study to know how much support you need. And so we give not too little and not too much support. The key thing is the mask has to fit. There are many interfaces: nasal, nasal oral, full face mask, nasal pillows. And if the mask is uncomfortable, the kids will tear it off their face. And I like to say that there are many different faces, and therefore there have to be many different interfaces. There are many ways of breathing, and on this slide here, you can see that there's oronasal, nasal pillows, full face mask. People have even used mouthpiece in sleep, which is unusual. I've never used a helmet like that, but that could be done as well. There are many ways of breathing without having to have a trach in place. I always like to point out that non-invasive ventilation is not new. It's been around since the 1950s when the polio epidemic was around. And what's really interesting to me is that if you help a person breathe when they're sleeping, they'll breathe better when they're awake. Why is that? Is because you're allowing the muscles to rest and they're stronger during the day, possibly? Or is it because you're resetting the body's sense of what is a normal set point? And I think it's more having to do with the body's sensitivity to CO2. Because if you're chronically retaining your CO2, then your body gets used to it and has compensatory mechanisms that allow you not to feel short of breath. And so I think that what you do is you reset back to normal every night. This is a paper from the great Anita Simons showing that people who are given respiratory support during sleep breathe better awake. Their CO2s go down, their oxygen levels go up. When you need help with breathing during the daytime, that used to be when we placed a tracheostomy, but not anymore. Most patients can be managed with mouthpiece ventilation with a lightweight ventilator mounted behind the wheelchair. And here's a picture of a patient of mine. His name is Kevin, and you can see that he has a ventilator mounted behind his chair, and the mouthpiece is held in place by what essentially is a gooseneck. It's a flexible metal rod that holds it right in the right position, angled mouthpiece. And he did really well with this. You can see there's a dog on his bed. Has nothing to do with his mouthpiece, but I would say, hey, what's your dog doing on your bed whenever I see this picture? And so the key thing is he's out and about. This is a guy who's not stuck at home. He's doing stuff. He's going around and he is living his life. And he feels much, much better because he is able to breathe and not be short of breath, and yet not be attached to a machine. Here's another patient of mine, and with a little bit of a different interface. And this is made by a company called Respironics, Philips Respironics. He has a nice Ferrari shirt on, like that for those of you who like cars. And he did very, very well with this. Again, never needed to have any kind of invasive support. Never needed to be on a ventilator. Never needed to have a trach placed. And here's a patient of mine graduating from law school with a mouthpiece ventilator, and he wound up actually working as an attorney in Pittsburgh, um, and never had to have a hospitalization or any kind of uh, sort of emergency interventions. Uh, that he never got pneumonia because he got really good care, and he was very compliant with his respiratory support. Never had any respiratory complications, and never had pneumonia ever since I managed him. And I'm not saying the world needs more lawyers, but it's great to know that a guy like this could get a job as a lawyer when his parents were told he wasn't going to even survive to graduate from high school. And so I'm kidding about the lawyers. I'm married to a lawyer, and so I can say that. And so I like to point out Patrick's story because there's wonderful breakthroughs happening in this field right now. But we have to live with what's available to us right here and right now. And there's a great deal we can do to help our patients and go on, let them live the most full life possible. And that's really my goal. And that is my last slide. And I think we have lots of time for questions. And thank you for your attention.